This is a frontal view of a cast corrosion preparations of the heart, and note that we see in grayish color the ventral cardiac chamber, which is the right ventricle, which continues with the pulmonary trunk. Note the right coronary artery and its branches in red, and the left coronary artery and its branches in white. In front of the outflow tract of the right ventricle, branches of the right connect with the branches of the left anterior descending division of the left coronary artery. And this cast corrosion is almost reproduced by this specimen of a in vivo human heart studied with ultra-fast computer tomography with electronic reconstruction. Note the epicardial portion of the coronary arteries that are seen in the surface of the heart, and we can see the left anterior descending division of the left coronary artery, which corresponds to the same left anterior descending division seen in the cast corrosion preparation. The next image is after subtracting the heart. We see just the supravalvular portion of the ascending aorta giving off the left coronary artery, and particularly in this section we can see the electronically reconstructed anterior descending division of the left coronary artery and the diagonal branch. When we turn the patient into a left anterior oblique projection at 45-degree angle, we can see that the left anterior descending division of the left coronary artery runs in the anterior portion of the interventricular septum, in the interventricular groove, in the epicardial surface of the heart. Note that the surface of the left ventricle and some of the anterior surface of the right ventricle have blue branches coming off the left coronary artery, and note that the right coronary artery depicted in red has branches which cross the ventral aspect of the outflow tract of the right ventricle, and this is so-called conal artery, and they anastomose by inosculation, which means telescoping comparable branches of the left anterior descending division of the left coronary artery. In its proximal third, it gives off the left conal artery branch. In this electronically reconstructed image of the heart, we can see in the epicardium branches of the left coronary artery. This study was done by intravenous coronary angiography, and by electronic means we can produce an image of the heart which is comparable to the oblique image seen in the cast corrosion preparation, and it is usually informative when we are looking at the proximal portion of the coronary arteries. We also note in this next cast corrosion preparation that the left circumflex branch of the coronary artery runs horizontally in the atrioventricular groove, somewhat perpendicular to the main left coronary artery, and gives off branches that supply the free wall of the left ventricle. In this patient with an in vivo coronary angiogram, we can see tight stenosis of the left main stem. This is a lesion that can either be dilated or treated by coronary bypass technique. Note that the left anterior descending and the circumflex branches appear to be free from atherosclerotic disease. This is a lateral view of the heart seen from the left side. The anterior chest wall is to your left and the dorsal aspect of the patient is to your right. Note the pulmonary trunk, which is a cephalic extension of the right ventricle. Note the left auricular appendage, which obscures or covers the circumflex branch of the left coronary artery. Note that the left ventricle is supplied by white branches that come off the left anterior descending and the circumflex branch of the left coronary artery. This is a specimen comparable to the next one, where the left ventricle was casted in blue plastic and is covered by abundant branches coming off the anterior descending and the circumflex branch of the left coronary artery. The first large branch coming off the anterior descending has been called the diagonal branch, and the large branch dorsal to this vessel which come off the circumflex have been called the branch to the obtuse margin of the heart, or the so-called margo obtusus branch of the left coronary artery. We can see in this other cast corrosion preparation where the left coronary arteries were injected in blue plastic that there are blue vessels that cover the free wall of the left ventricle, and we also note that the left auricular appendage partially obscures the course of the left circumflex branch. In this lateral coronary angiogram, one can see the course of the left anterior descending, which runs around the apex of the heart, and we can see also that the patient has a very small circumflex branch of the left coronary artery. We can predict that this patient had a dominant right system because of the smallness of the circumflex branch of the left coronary artery. Note the vessels that come off the anterior descending, particularly the diagonal branch of the left anterior descending coronary artery. Angiograms of the coronary arteries must depict the vessel in multiple projections. As a minimum, 2 opposing oblique views, usually with an angulated X-ray beam. This is a left posterior oblique view of a cast corrosion preparation where we can see the right coronary artery and its branches in red. Note a prominent right coronal artery, and also note a prominent posterior descending division of the right coronary arterial tree. This patient certainly had a dominant right system. Note in white the left anterior descending branch of the coronary artery. In the next angiograms, we're going to see in the left posterior oblique projection the left coronary arteries. Note a normal left anterior descending, and note a circumflex branch which stops at the crus of the heart. The crus of the heart is the junction of the interatrial and interventricular septum and the atrioventricular groove in the back of the heart. Crus means cross, and it is there where the right coronary artery normally bends and continues, usually as a posterior descending branch of the coronary artery. It is also there where we see the origin of the branch to the AV node, which usually comes off the curve formed by the right coronary artery. In this next left posterior oblique view, we see a focal stenosis of the proximal left anterior descending, and note that this patient has no left circumflex, but we can see a large left atrial branch coming off the branch to the obtuse margin of the heart. The way to detect a left anterior descending is to note that it gives off the septal branches, which are parallel vessel coming off perpendicular from the undersurface of the left anterior descending, and they usually supply the ventral 2/3 of the interventricular septum. They usually can anastomose with similar branches which come off of the posterior descending coronary artery, usually a terminal part of the right coronary artery. Usually the ventral 2/3 of the interventricular septum are supplied by the left anterior descending. Another criteria to recognize the LAD is to note that it curves around the apex of the heart. It becomes the longest branch of the left coronary arterial tree, as seen in the next angiogram, where you can see prominent septal arteries and the LAD going around the apex of the left ventricle.